Thank you, Dai. So quickly introduce myself. Nana, I'm program lead for Healthy Hearts. I work with Manchester Local Health Organization, and I'm here with my colleague, Salima. I was supposed to be here with one of our colleagues, Charlie, but unfortunately she couldn't be here. So I'll bring in Salima to introduce herself.
Hi, my name's Salima Jones. I work for Manchester's Public Health team and also part of Winning Hearts and Minds team, a programme working based in Manchester, but particularly in North Manchester, addressing health inequalities.
Right. So I think Di has kindly sort of introduced, the project, shared a few, insights around it as well. Quickly moving to this particular slide, which sort of talks about the partners that we worked with. Again, Di mentioned that, which is really key for the success of this project. And again, I'm going to bring in Salima to share a few insights on that. So you can see the logos of, Winning Hearts and Minds, VHA for equality, and then CAN, and then that logo over there, which was co-designed for the project that was, delivered. So again, a brilliant logo. I'll bring in Salima to explain that.
So the logo was co-designed with people when we organisationally talked to local residents about heart health and being healthy. The phrase hearty and healthy was a way of people describing their heart health, so healthy and hearty. The logo is a heart, obviously it's a heart health project. It's also got a black woman with a scarf, and the scarf is very cleverly designed with both fruit and vegetables in it, but also your actual heart shape, so your medical heart. So that was very much designed and used on all of the literature to help engage people and show it was for them, not just for the wider population.
Moving on to this slide, just to again touch on, I suppose, the rationale behind why we decided to do the project. Again, Di has touched on it a bit, and it's been interesting hearing all the different speakers who spoke earlier about, innovation and using tech as well. And which is brilliant, helping using tech and innovation to sort of improve health outcomes and reduce inequalities. But that begs the question, how do you use innovation and tech in a way that actually reduces inequalities and narrows it, as opposed to widening all of that? So, going on to the slide, we had a look at the health inequalities and what it was saying for us as a locality. And you can see the figures and the stats on there for Manchester. Huge numbers in terms of poor outcomes around CVD. And again, so you ask why CVD and why the communities that we worked with. So we worked with the Black African, Caribbean, South Asian communities because of what the data was saying. And I took most of this from Health Innovation Reports that was done, brilliant reports done last year, actually. I'll bring in Salima again to touch on some of the reasons why we decided to go with that.
As you can see from the figures, it's a really big issue for Manchester, but there are certain parts of our community that are most adversely affected by health inequalities. So people living in the most deprived neighbourhoods are much more likely to develop heart disease. Those experiencing discrimination, racism, language barriers, and also have lower trust in healthcare systems are less likely to access either preventative or screening opportunities. And as a result, many people present later, develop the diseases we're trying to prevent, and or die much earlier than they should do. So it's a really key thing for us in Manchester to be addressing this. If we get this right, we can help other people. So although we focus on this community, some real learning for other parts of our communities. I'm mindful of an earlier question, for example, of specific communities.
So again, trying to understand and then sort of the rationale behind it, we moved into identifying some of the barriers. And this slide doesn't do justice to it at all. It's not exhaustive. So you have on the left the barriers and then what our response were. So you have challenges in accessing clinical environments and formal health settings.
So we delivered health checks, the NHS ones that you normally go to your GP practice, but we delivered them in trusted community spaces rather than clinical environments.
Again, it's been touched on quite a lot today. So you had low trust in health systems, particularly among racially minoritized communities.
And hence we partnered with VCFE organisations with strong relationships in local communities.
And then for those who had higher cardiovascular risk and lower uptake of routine health services,
we specifically engage communities from those experiencing the greatest disadvantage and health inequalities.
Things around language and communication.
So we designed And the logo is one example with our community's culturally appropriate materials, sessions, the way we talk, the way we delivered the health checks, and particularly support for people whose first language isn't English.
And then finally, around limited pathways for higher risk residents to access further support.
One of the things we wanted to do was identify those that are highest risk and supporting them to access mainstream provision, whether that be primary care or secondary care, if the health checks identified they were at risk, for example, very high blood pressure.
So this slide sort of, again, chronicles the journey. I've already mentioned the understanding for and then the rationale for this project, but then we had to build to be able to deliver this project, and it's been coming since 2019, really. So again, I'm going to bring in Salima because she does justice to the slide to explain where it all started from and how it chronicles from the Winning Hearts and Minds ways of working to the SDF project that I mentioned, CLF in the north, then the point of care projects that we're talking about, and now we have AF and Lipids, which we're delivering in the north at the moment.
We've used this slide really to show the journey we're on. Although we're going to be talking about that green column, point of care testing, we actually started with conversations with Health Innovation Manchester, Charlie, Nick and myself in Winning Hearts and Minds around what to do in Manchester. But we've been on a journey with through 3 sets of funding, and we're currently delivering a project about AF and lipids. But the point of care testing wouldn't have happened if we hadn't have done the earlier stages. What we did was develop relationships. We built trust. We started to work together in a way we hadn't done before. Most of us had not worked together, but also we developed the trust and relationships with the communities. So just saying I'm going to deliver a health check in a community setting, I go to a community centre or a faith centre, doesn't mean it's going to happen straight away. It doesn't mean people are going to attend, doesn't mean we're going to find the right people. So the journey we've been on has been really significant and takes time. And I guess if there's one message that you want to take if you're going to do something similar is you are on a journey, we're on a journey, and our patients and our residents are also on a journey in terms of accessing healthcare in a very different setting.
And again, just to add that it shows that a project didn't just emerge overnight. It was sort of from one stage to the other, building trust and then the relationships as well. And then working with the same partners on all of these projects has been really key. So I'll do the slide before I go to the other one. In terms of the project timeline, another very key aspect of it was that we had to work with our clinical partners to help train our, VCSE partners to deliver this project. And what we had in mind was the legacy of upskilling our VCSE partners to be able to deliver beyond the project. And so they went through some very rigorous training to be able to deliver some of these, the checks really. So we had that in autumn of 2024, which then took us to December 2024, where we actually started delivering the health checks. And by March 25, we had achieved about 300 health checks. And then we had an interim evaluation, and we were hoping to achieve 500 at the end, where I think we achieved about 460 or 69, if I'm not mistaken. And then we had the evaluation of the effectiveness of the project, which brings me to how the checks were actually delivered on the day. So we had the checks being delivered at community spaces which are familiar to the people we're trying to reach and not reach actually. And there were working appointments because again, I saw Salima will touch on it a bit. We've got a provision by a partner organization called Be Well. So they do community health checks as well. But that is appointment based, similar to the GP health checks. What we were doing were opportunistic checks in a community space. You can just walk in and have it. And the added value was when you go to have your NHS health check in the GP, you only have about 10, 15 minutes to do that and have a conversation. We were providing people 30 minutes, upwards to have conversations, wrap around, just unpack anything that you have, because again, it's not just about CVD and diabetes. There are other things as well. So we had that. And then in terms of the process, the patient is able to receive the results on the day, straight away, 30 minutes, as compared to the GP health checks. Again, I'll bring in Salima to talk through the next two.
So one of the key things was having the results there and then. So the point of care testing machine really enabled us to be able to do that. So it wasn't saying phone back for your results at 2:00 2 weeks later. It wasn't saying book an appointment. It was saying we can do that while you're in the conversation, in the appointment with us. And also meaning you can ask questions. The results were explained. So if someone had something that was an indication that you might want to keep an eye out, that conversation was part of it. If we identified you had something quite high and we needed you to see a medic, we would talk to you about how to do that and support you with that access. And also providing to additional support. We know people's health isn't on its own. Where you live, what you're working, your family circumstances all come into how engaged people are in terms of accessing healthcare. And so Be Well is one of those organisations that we signpost to. But also importantly to know, the 3 voluntary sector organisations delivering also provide support in their communities. That's what they do. That's their core business in terms of really being embedded in communities. When those results came through from the point of care testing machine, they were also shared electronically with the GP. So it goes straight into the EMIS system in the GPs use, which means GPs can see what's happening in their communities with the patients that are not coming forward. So these are not you and I that might be going. These are people that probably wouldn't ever book a health check. And that system allows the GP to flag if there's something that needs to be follow-up. So it might be follow-up tests, it might be a different conversation, but it's allowing them the relevant information to start that dialogue with the resident.
So we come to this slide, which is what was different about what we did. And again, we've alluded to it a bit, but just in more detail. We weren't just working in a vacuum or in isolation. We're actually sort of evidence-basing everything we were doing. So here you have a slide of the Race and Health Observatory principles. And we went with a third one, which says meaningfully involving racially minoritized individuals in everything you do. And that's exactly what we did right from the beginning, doing the co-production stuff, getting them embedded into being trained to deliver the spaces that people were targeting. Everything spoke to that particular principle, and that was underpinning everything that we did, really. Anything to add? Here you have the key info, so I'll quickly run through in terms of the number of participants that, took part in the health checks. We had 459 participants, and just key highlights, 54% lived within the most deprived areas in the country, mostly in the north. And from the Muslim engagement that Khan did, we found that English was not the first language of 69% of the people that took part of the health checks. 71% were female, 34% identified as African. So there's still a gap in terms of engagement with men, and we're getting there gradually. But that was something good that came out of it, actually. Again, anything to add?
I think we're on a journey, and where we identify figures that tell us. So, for example, if you look at the female percentage, we are then looking at how do we reach men? Where do we go that men are that women may not, and vice versa? How do we approach it in a way that reaches people? And similarly, the range of backgrounds you can see, that's why we've got a range of organisations. There's not one that can reach everybody. So we're making sure we're using our specialist knowledge in our voluntary sector to make the best ways of reaching people.
And again, this slide shows that we didn't identify a gap in data. We found it in people, really. In terms of impact, again, the high-risk patients that were identified. So for Q-risk, we found 7.1% having high Q-risk. We found 50.9% having high cholesterol. For blood pressure, 26.1%. And then for HbA1c, 15.2%. And that is really alarming because I do a lot of work around diabetes, and it's very alarming to know that people are walking around not knowing that they are pre-diabetic or diabetic. So those are the figures that we found. And again, just going back to some of the slides that Sarah shared earlier on, she touched on cost saving to the system. If you're to run these numbers by what she shared, your guess is as good as mine, really, in terms of cost saving. Finally, on the survey results that we got, so they've been categorized in terms of access, experience, having the health check itself, and then patient information that's provided to them. So again, I'll do the two, and then I'll hand over to Salima to do the two as well. We had 96% of people who partook in in the project saying, the health check was easy or very easy to access. And they thought it was sort of, because it was in a community setting, they found it valuable. 99% of the respondents described experience as being good or fairly good. Bringing Salima.
So 100% would have the finger prick test in their community setting. And that's the key crux of this. We were doing this with a device that enabled us to do that in a community setting. You weren't having to book an appointment with the phlebotomist department or booking an appointment with a nurse to get it. You were getting it there and then. And nearly 70% found the process easier or better than taking blood from your arm. And similarly, patients stated that the information we gave them was clear and easy to understand, and they were able to walk away with better information about their health and ask questions so they could go away and have different conversations following the health check.
So this is where I bring in our delivery partners who did all the work, really. I bring them in to share the experiences and some of the insights they picked up as well. So I'll hand over to Donna now.